What I would like to share with you is from my perspective as a pediatrician, as a practicing pediatric infectious disease specialist, and a preventive medicine person, and state health officer, I would like to talk about it from my perspective in those different venues. Just some general comments. You know, antibiotics were first employed in about the 1940s is when they really came into it, after Florey & Chain's purification of penicillin. Now, they didn't invent penicillin, that was Fleming, but they're the ones that actually purified it and made it available, I think, for usage. And I think all of us realize the importance of antibiotics, vaccinations, and sanitation and the resulting marked decline in some of the deaths from infectious disease worldwide because of those. But in recent years, as we've been talking about and as we heard from our CDC colleagues, there has been much attention, particularly on antibiotic resistance, whether it be nosocomial infections with VRE and other things, or whether it be community-acquired resistance that's rising with strep pneumo, E. coli, salmonella, and a number of organisms that we've heard about. It is an evolving problem, and it spans all healthcare settings. This slide just lists some of the major antibiotic categories that we utilize now over the last 71 years since Florey & Chain, and I'm not going to go through those, but I think this demonstrates that the field of antibiotics is vast. And it's not only for human use, but also for animal use. So why do we use antibiotics? And I think this kind of lists three of the things. Number one, we use it to treat infections, whether it be infections in humans or infections in animals. We also use it to prevent infections. In humans, there are a number of surgical situations that we'll use prophylactic antibiotics to decrease secondary infections. We use it, have used it in the past and still use it for dental prophylaxis in certain situations to decrease endocarditis. And we use it in individuals who have neutropenia, low white blood cell counts sometimes, to hopefully prevent infections. In animals, it's used also, from what I understand, to prevent disease when animals are susceptible. But then the third thing that antibiotics are used for, particularly I think in animal situations, is to promote growth, whether it be with cattle, with poultry, with swine. And I want to take just a few minutes to talk about that latter situation, promote growth. And I think this is important to consider in the discussions that will be taking place the next few days here. To think about the food needs of the growing world and the significant concern that has and brings to this discussion. This is an estimated data from 2010. During that year, it was estimated that there were 925 million people that were significantly hungry worldwide. That's 13.7% of the world's population. And as you can see from this pie chart, 88% of those were from sub-Saharan Africa, Asia, and the Pacific area. As a pediatrician, I understand very clearly that children are at the greatest risk for malnutrition and undernutrition. In fact, a malnourished child will spend about 160 days a year ill. That's almost a half a year ill when they're malnourished. I think we also realize, when we look at some global statistics, that over half of the 10.9 million deaths of children per year are associated with malnutrition. And one of the things that I used to see in my work in Zaire, which is now the Democratic Republic of the Congo, realize the impact of malnutrition on other diseases, whether it be malaria, whether it be diarrhea, or whether it be measles. So adequate food production for an expanding population, particularly children, is key. And I think one of the things that we realize is that animal proteins are more bioavailable than plant proteins. It's because the amino acid profile of animal proteins are similar, more similar to that of humans, and therefore more easily absorbed. So I think we need to consider the potential risks as we talk about that with antibiotic usage in animals, but we must balance that also with the growing need for food worldwide. So I think when we start talking about who needs to be involved in this discussion in the future, we need to also have individuals who are involved with global health at the table to discuss this. Now, once again, I'm not an expert on this, but I've had to educate myself a little bit. The real experts on animal health and animal antibiotic usage are other folks here that are in the room. But you have to realize that I come from North Dakota. North Dakota is an agricultural state, and it even gets a little more personal than that. I have a ranch out in the western part of the state. We have animals. Those animals are really important to us, and their production is really important to us. So once again, I've had to kind of educate myself, and forgive me if some of this is old hat for many of you. But I think back in the 1950s, there were some studies that actually focused on the use of antibiotics in animals and demonstrated that animals, when given a low dose of antibiotics for a period of time, gained more weight for a given amount of feed versus untreated animals. I think in swine, there was about a 3 to 9% improved weight gain when they were given antibiotics, 3 to 7% improvement in feed efficiency versus those that were not given antibiotics. But one of the caveats that I have seen in some of the literature is that the greatest benefit to animals was when feed composition, management practices, and the health status of the animals was not optimal. And it seemed as though that benefit of using antibiotics declined significantly when those other things were more optimal. Now, one of the other things that I think we have to think about is what is the potential action of antibiotics in animal growth? And I think these are some of the things, and I'm sure that others here would probably add to these things. First of all, it may eliminate bacteria that steal essential nutrients. A second thing, it might reduce competition with beneficial bacteria that produce essential nutrients. And third, it may control the growth of bacteria that cause low-grade infections and or toxins that decrease nutrient absorption. Now this slide is actually from historical data, and it's not exhaustive, and it's not meant to reflect current practice. But in the left column, as I looked at some of the historical information out there, lists some of the antibiotics that have been used, some more than others, in both human medicine and also to stimulate animal growth. And the second column just kind of lists some of the antibiotics that were historically used almost exclusively for animal growth. Those being the ionophores, bambermycins, etc. The ionophores are some that we don't use in human medicine at all, like lasalicid and monosin. But one of the ones that does fit into that category is nystatin that we use, obviously, to treat various yeast infections. But I think when we look at those two columns, we understand that historically, depending on the choice of antibiotics for supporting animal growth, that there can be overlap in several categories. And whatever the current usage is to utilize antibiotics in animal growth situations, choice may be important. And we need to think about that in our considerations as we move forward. This slide just lists, and Dr. Solomon mentioned this, so I'm not going to spend hardly any time talking about this, but lists some of the human infectious disease organisms that have caused concern due to the development of resistance over the past couple of decades. Whether it be strep pneumoniae with resistance to penicillin, cephalosporins, erythromycin, quinolones, E. coli with its resistance that's developed to ampicillin, trimethoprim sulfa, quinolones, Neisseria gonorrhea used to be a relatively easy to treat with penicillin. Now they're resistance to penicillins, quinolones, and cephalosporins. Neisseria meningitidis to penicillin, a study that was actually done even back in 1997 in Spain demonstrated a 71% resistance to penicillin for Neisseria meningitidis. Salmonella, we heard about the resistance patterns there, particularly with Salmonella typhi. Shigella, we heard about the percentages in Shigella. There was a study back in 1999 in Minnesota, our neighboring state, where there was an 85% not susceptible to ampicillin and a 25% resistance to trimethoprim sulfa. So there's quite a variation around the nation. Staph aureus, we've heard about MRSA. A 19 to 80% colonization in certain areas. It all depends on what group of people that a person represents. There's a higher rate of colonization in Native American individuals. I know in my clinic that I have up in the northeastern part of the state on a reservation called Spirit Lake Nation, we at least have 80 to 90% MRSA colonization. Almost all of the superficial infections I deal with are MRSA. And if you have individuals coming from the South Sea Islands, particularly Samoa, a very high rate, or those that are mentally disabled patients. The other thing that's of great concern to me as a clinician is the rising resistance in MRSA to mupirocin resistance. We're seeing now in some situations a 45% resistance. We use that mupirocin to sometimes decrease the colonization, to decrease surgical infections. Enterococcus, vancomycin-resistant enterococcus is of great concern for nosocomials. Mycobacterium tuberculosis, you've probably heard about the multi-drug resistance and the extra-drug resistant tuberculosis, and even pertussis. We're in the midst of a epidemic of pertussis in certain parts of the United States right now. And there is some emergence of erythromycin resistance, and I know that was reported as long ago as in 2000, I think, in Minnesota, some resistance to that. So what are the reasons for resistance? And this is kind of what I kind of view as a pediatric infectious disease person, probably two in the literature. Probably the most important one that I can find is inappropriate antimicrobial prescribing. I know that definitely occurs in human medicine, and I don't know how much that occurs in veterinary medicine, but my guess is that it probably happens too. And if I were looking at the three most common causes of, or the buckets that are associated with inappropriate antimicrobial prescribing, first of all, overuse. We heard some discussion of that already. Treatment too long. Second one is inappropriate dosing, and the third that we oftentimes deal with is the use of broad-spectrum antibiotics as a first-line treatment rather than using more narrow-spectrum drugs. And then the second one is one that I know is a focus of kind of this meeting, is animal applications in food. So those two, inappropriate antimicrobial prescribing and animal applications. Let's just take a look at inappropriate use. And this was touched on by Dr. Solomon already. And this comes from human medicine, just a couple of studies to give us some numbers to look at. This looks at prescriptions. This study actually came from material that was developed back in 1992. It wasn't reported until 1997 and 98 by Dr. Gonzalez. But at that time, 51 to 52%, depending on which category you're in, of people that had colds or upper respiratory tract infections received antibiotics. Now, obviously, those are caused by viruses and then respond to antibiotics. 75% of people who had bronchitis, which very commonly is caused by virus, also were given antibiotics. This was another study that actually confirmed it. This was in adults and children. This is from 2003. 46% of patients with the common cold or nonspecific upper respiratory tract infections received antibiotics. And also, they generally tended to receive more broad-spectrum antibiotics versus a narrower spectrum. Now, why do they do that? Well, one of the things I think that was kind of alluded to in some of the previous presentations is patient pressure. That's an issue in human medicine. In fact, I remember I had a patient that came in when I was a relatively new pediatrician in Bismarck, and that person came in, and the mom, a child came in, and the mom said, he's here to get his penicillin shot for his cold. And I told her, I said, well, I examined him and said, yeah, he's got a cold, but he doesn't need a penicillin shot. Well, she got angry, and she walked down the hallway to another pediatrician and got her penicillin shot for the child. There is pressure from patients and patients' families to use antibiotics. And this is from an article from Emerging Infectious Diseases by Dr. Eng. 32% of patients believe that taking antibiotics during a cold will prevent more serious illness. 48% expected antibiotics when seeking medical care with a cold. And 58% were not aware of any health risks of taking those antibiotics. Now, I don't know about you, but this means that there's a knowledge gap out there in the public regarding the use of antibiotics. What are some of the human health hazards that may come with veterinary usage? And once again, I'm not an expert in this area, but these are just things that I have read. First of all, with salmonella, I think Dr. Fay actually wrote an article on this in 2000 in the New England Journal of Medicine. Salmonella, a case of ceftriaxone resistance, was traced epidemiologically to cattle isolates in a region. Another article in New England Journal of Medicine. This was glycopeptides. Glycopeptides are like vancomycin and avoparin. Now, avoparin, I believe, is used in animals in that situation, in poultry. It was associated with a resistant Enterococcus faecium of animal origin, and it was found in the stool for 14 days in humans after the ingestion of infected animal products. Another one, New England Journal of Medicine article, this was from 2001. This was in the streptogrammin group. This is where you have virginomycin, and it's in the same group. There's another antibiotic that we use in human medicine that's a combination, quinupristin and dalfopristin. And virginomycin is used, I believe, in poultry. And it was interesting that quinupristin and dalfopristin resistance was noted in a large portion of chickens that had been given virginomycin. And they were looking particularly at Enterococcus faecium. In fact, 237 of 403 chickens that were evaluated in this study were found to be positive for that resistance. So it seems as though there was a suggestion that there was this cross-resistance that was taking place with virginomycin cross-resisting with and causing cross-resistance with quinupristin and dalfopristin. And then just the last one was from Chu. This was 2002, New England Journal of Medicine. Salmonella enterica, fluoroquinolone resistance, which epidemiologically seemed to be associated with spread from swine to humans via meat. So does animal antibiotic use increase antibiotic resistance in humans? There are some historical base articles, I think, that come from the 1990s that seem to be a compelling argument, at least to consider that. In Europe, in the 1990s, avoparin, one of those glycopeptides that we talked about, was used to boost growth characteristics of chickens and pigs. And avoparin-resistant bacteria emerged in these animals. And they also noticed at the same time that other glycopeptide that's used in humans, vancomycin, resistance was also noted to increase parallel to that avoparin resistance. The European Union then banned the use of avoparin to improve animal growth in 1997, and avoparin-resistant bacteria in poultry and swine decreased to 0. And resistance to vancomycin in humans also saw a drop as well. And the take-home for me on this was not necessarily that parallel course, which makes you think that there could be a connection there, but that resistance can be reversed. I think that we heard that. Dr. Tux was talking about that. That if we decrease the use of antibiotics that organisms have or are becoming, that have become resistant to, that there is a reversal of that resistance that can be seen in populations. And that should be really encouraging to us. One last one is in the United States, 1990s, Campylobacter resistance to fluoroquinolones increased. As we had heard, Campylobacter is a commensal in the intestine of chickens. People can get infected by eating undercooked chicken. In 1989, as we saw, I think, in the chart earlier, none of the Campylobacter strains from ill people were fluoroquinolone resistant. In 1995, the FDA approved the use of quinolones in poultry, and soon thereafter, Campylobacter strains from ill humans were noted to have become resistant to quinolones. Is this coincidence or is this association? That's something we need to think about. So what can be done? These are probably just some very basic infectious disease concepts to consider. And we've already heard many of these. Number one, use antibiotics only when indicated. In human medicine, that means not when they have colds or URIs. The second thing, utilize the least broad spectrum antibiotic possible to decrease antibiotic pressure for advanced spectrum antibiotics, and hopefully keep those things in our formulary in human and animal medicine longer. Use antibiotics for the least amount of time possible, getting back to some of the research that was talked about, that Dick had mentioned. We don't utilize even antibiotics now in children who are over 2 years of age with otitis media anymore. We don't recommend that as a pediatrician. Children under 2 with fever, we still do, but we also limit the amount of time. We don't necessarily go 10 days anymore. Use adequate therapeutic doses for targeted organisms. And then the last two may be particularly related to some suggestions or thoughts and concepts that we might have in animal usage. Use non-human categories. Those are antibiotics that are not commonly used in humans when at all possible. And when using crossover drugs that are used in both animals and humans, try to choose antibiotics that have the least impact on humans. So if resistance does occur, it will influence at least the least number of people possible. And then the last, which I think was kind of mentioned by Dr. Taux, appropriately monitor cultures and sensitivities. We have a little bit of a problem in human medicine right now. We have a lot of non-culture techniques to diagnose. And we're using more and more of those, and my folks in disease control in the state health department are becoming more concerned because we're not getting cultures and sensitivities anymore. And it's very difficult for us to determine when you're developing resistance if you're not doing cultures and sensitivities. So my guess would be that we need to continue to do that and get cultures appropriately to monitor for these resistance patterns. We do need to have that surveillance of cultures. We've already mentioned, and just want to reconfirm that, from my perspective, this resistance reversal can occur. Just to give you a couple of examples, in Iceland, penicillin-resistant strep pneumo rose from 0% in 1988 to 20% in 1993. There was an intensive informational campaign for physicians and some regulatory changes which actually required people to pay for their prescriptions in Iceland. Those two things resulted in a marked decline in penicillin-resistant strep pneumo from 20% to 15% in a 2-year period of time. Also, there was some resistance reversal in Finland. Macrolide use tripled in the 1980s, and erythromycin resistance for group A strep rose sharply to 17% in the early 1990s. That resulted in a national education campaign for physicians on appropriate use of antibiotics, and resistance declined to 9% from 1992 to 1996. And this next one is kind of a personal thing. Policy can influence appropriate usage and resistance. Back in the 1980s and early 1990s, I was in charge of infection control at a large healthcare institution in Bismarck. And we noticed that there was a marked decline in the appropriate use of advanced spectrum antibiotics for gram-positive as well as certain gram-negative organisms. And in fact, it had declined to only 65% of the antibiotics were appropriately used. So we did a little more prospective program. And we decided to require that every advanced spectrum antibiotic on our list that was ordered within 24 hours, physicians were given a form that they had to complete justifying why they were using that advanced spectrum antibiotic. And we actually used the medical letter list of indications and then gave them an option for other uses. Well, my infection control nurses would review that against the chart. And if there was no justification, it resulted in an automatic infectious disease consult by me. And I would review that, and I would make recommendations in my consultation. And if there was still no justification and there was no change in that antibiotic, we were given the ability to rescind their privileges. Never had to go that far. But one of the things that I can mention is that within a matter of 6 to 8 weeks, the appropriate use of those advanced spectrum antibiotics increased to 95%. And we started to see a downturn in the resistance patterns of the organisms that we were dealing with. The other thing that we did notice as kind of a sidelight was the education of the physicians. Because I had to watch myself walking down the hallway. This wasn't the most popular program in the world. But those physicians could quote, after 4 to 6 weeks of the antibiotics that they commonly used, they could quote the indications for us. They knew them by heart. So there was an educational potential there. And then this just goes on to 2 other studies that I'm not going to cover just for time. But I want to come to my last slide, which are what can we do? And 4 tactics that we can consider. And I think this reinforces some of the things that we've already heard from our CDC colleagues. Number 1, public information campaigns may be something we should consider to inform the public regarding inappropriate antibiotic use and adverse effects. What we want to do there is change, if we can, the public expectations and make them more appropriate. The second thing is intensive informational campaign for MDs. These would be clinicians and veterinarians.
Lost.
Oops, we lost it.
I think they got short batteries.
Were those Energizer Max? Intensive informational campaigns for clinicians, whether it be physicians and or veterinarians. And there are some really good studies that have shown, and I'm just going to mention 2 of them very briefly. One in Wisconsin, where they use these 2 strategies, intensive informational campaigns for the public and for physicians, and solid antibiotic use. These are pills, had a 19% decline in the intervention group versus 8% of the controls. For liquid antibiotics, from a pediatric point of view, that's my group, they had 11% decline versus a 12% increase in the controls. What that tells me is that those informational campaigns may work. Another one in Denver where they did the same thing, focusing on the public and the clinicians, antimicrobial usage for bronchitis decreased from 74% to 48% with no change in the control groups. The third thing that we might be able to do is proactive hospital antibiotic usage programs. And I'm not saying just what we did in Med Center 1 in our healthcare system there is the way to do it. There are probably a lot of other ways to do that. But one of the questions that we have, it's kind of easy in a hospital. We've got control. If those folks want privileges, you can put teeth into policies there. But when I get out to the clinics, I don't know exactly how we're going to do that. And I think a question that I would have for our veterinarian colleagues is, would there be some proactive policy things that we can do to help clinicians better use antibiotics? And then the fourth thing that I would like to leave you with is I think one of the reasons why they're bringing all of us from various backgrounds together is that, public health people, clinicians, and veterinarians, and the animal folks that deal with animal husbandry and agriculture oftentimes operate in silos with very little awareness and or coordination and collaboration. Maybe it's time for us to have a little bit more collaborative and partnership work together to talk about things. And I would be greatly interested, as the chair of the Infectious Disease Policy Committee for ASTO, and I know I speak for my committee, we would be greatly interested if there was interest of other parties in getting together and talk about how public health, how human medicine and veterinary medicine can work together on a comprehensive program to hopefully deal with resistance in these United States. Thank you.